Hello, you beautiful people. We meet again with a new topic. Today I am merging rheumatology with nephrology. Any guesses for today's topic? Yes, as the title suggests, systemic lupus erythematosus. Honestly, I have bumped into such cases very often in my institute, yet these have either been diagnosed but have landed up in lupus nephritis or are undiagnosed and have crashed to death. And of course, we performed so many investigations, but being in a bad condition, we could not save the lives. Let's study this topic and try to apply the knowledge in daily cases and create a hope for SLE. SLE. Um, we have come across this ratio many times in rheumatology, 9:1, okay? Women to men occurrence, mostly in the reproductive age group. Now, if it occurs in child, it has a very bad prognosis because there is 100% renal involvement. Family history is of course important, so there is genetic as well as the environmental causes which are contributing towards the SLE occurrence. Pathogenesis lies in the innate immunity, so this is very important. The innate immunity is activated, okay, wherein there is activation, there is interferon alpha which is causing the antigens, okay. There is upregulation of the genes, and these are actually the antigens which are presenting to the T cells, which have been presenting to the T cells, and there is actually the T cell activation which is causing secondary activating B cells. So B cells are activated, and then we have the antibodies. Okay, so the genetic and environmental factors cause defective apoptosis, and there is actually a defective netosis, or new word, neutrophil extracellular trap. The interleukin 4, 12, 21, they are very important as they contribute towards the antibodies formation and the immune complexes are formed. Now, this immune complexes are getting circulated and then they get deposited in glomerulus, in synovial fluid and vascular system. So, this is actually a type 3 hypersensitivity reaction. Okay. Now, the genetic factors include the C1q deficiency. Now, the C1q can be involved and predict the risk for SLE. C1q antibodies cause hypocomplementemia urticarial vasculitis. So, very important, C1q, definite MCQ. Then renal biopsy, we get C1q of course. Other is the TREX gene. The number of the X chromosome influence the occurrence of the disease. HLA DR2, DR3. DR3 mainly involved in subacute cutaneous lupus. What are the environmental factors? So, S for smoking, S for silica, UVB. Then we have the ossipals, we have hormone replacement therapy, Epstein-Barr virus, and vitamin D deficiency. Okay, so 6 environmental factors, 3 genetic, 1. Remember, 6, that is silica, smoking. Then we have vitamin D deficiency, UVB rays, ossipals, hormone replacement therapy. Okay, and we have Epstein-Barr virus. Each of them can be an MCQ. Antibody profile. So, the ANA antibodies, that is the major one we are performing. 97 of the patients have this ANA antibodies positive. Now, this ANA is 100% positive in 3 conditions. Okay, so this is a drug-induced lupus, there is a autoimmune hepatitis, and mixed connective tissue disorder. So, ANA antibodies 97%, 100 in SLE, and 100% in case of MAD. That is, we have mixed connective tissue disorder, we have autoimmune hepatitis, and we have drug-induced lupus. So, ANA to be done with the help of indirect immunofluorescence. This is important. Okay, then its titers are important. So, first the patient comes with the symptoms, then if we are suspecting it, we are sending the patient for ANA antibodies, and then ANA antibodies to be done in indirect immunofluorescence. Then 1:80 titer, very important. It is the significant one. Again, after that we need to know the patterns. There are 6 patterns total. We have the first, which is the homogeneous, which is most common, antihistone antibodies, then anti-double stranded DNA antibodies, and we have the anti-nucleosomal antibodies. So, here is a picture. So, this is the homogeneous, that is the completely the cell is involved. Okay, so homogeneous pattern. Antihistone, anti-double strand DNA, anti-nucleosomal. Then we have a rim or peripheral. This is very important. This is more specific for the SLE. So, anti-double stranded DNA antibodies. Okay, it is because of the anti-double stranded antibodies. So rim or peripheral pattern. So rim or peripheral pattern. Then we have a speckled pattern. So the speckled pattern is mostly in connective tissue disorder. So in anti-UNRNP, or we have Rowe or La, anti-Smith. So this is the speckled pattern. Okay, anti-UNRNP, mixed connective tissue disorder, Rowe or La, that is the Sjogren's, and then we have the Sjogren's, and then we have the anti-Smith, that is SLA, right? Then we have a centromere pattern, C4C crest. Okay, crest syndrome. Antinucleolar pattern, that is in case of systemic sclerosis, specific for systemic sclerosis. So we need to know these. Do not repeat the ANA pattern, very important. First of all, it is only has the diagnostic value, not the prognostic. Okay. Then we have a symptom, we do ANA. If it is positive, we need to have the titer, then we need to know the pattern, and then we need to do the ANA blot. Specifically, we can know the disease. So we have anti-double stranded DNA. So anti-double stranded DNA, we have seen it is associated with homogeneous pattern, and it is also associated with that of rim or peripheral pattern. So it is done by immunoblot or ANA profile. ELISA gives us a quantitative measure. So anti-double stranded DNA is positive in 75% of the patients. ELISA gives us the titer. We have seen it is 95 to 96% specific. Whenever there is increase in titer, it is associated with nephritis and vasculitis. Okay, bad prognosis. Okay, so the titers give us the indication of the predisposing to nephritis, or a person being predisposed to nephritis or vasculitis. Then we have anti-Smith, that is the ANA profile. Okay, semi-quantitative, right? 99% specific. So very importantly, whenever a MCQ comes, which is the specific for SLE, it is anti-Smith. Okay, and it is, of course, we do double stranded DNA. So if it is saying, the MCQ is saying if the prediction for the nephritis and vasculitis, then we need to go for anti-double stranded DNA. Otherwise, it is the anti-Smith, which is 99% specific. UNRNP, we have already seen in case of connective tissue disorder. Rowe and La. Now, this is very important. Anti-Rowe and La, of course, if it is present in SLE, can be associated with secondary Sjogren's, and it is having a good prognosis. So if the patient is presenting with anti-Smith in the SLE, then it means that there is this decreased risk of nephritis and vasculitis. That means the risk with the anti-double stranded DNA is much more as compared to that of the anti-Rowe and La. So decreases the risk of nephritis and vasculitis in SLE. So mostly it is associated with myocardium and the skin involvement. So we have a photosensitive subcutaneous lupus, lupus myocarditis, neonatal lupus, congenital heart block. 1/3 of the patient of the SLE, we all know the statement, have APLA, so contributing to the thrombosis, and of course there are certain other antibodies, that is the anti-platelet and anti-RBC. Anti-RBC antibody associated with warm antibody, okay, autoimmune hemolytic anemia, and anti-platelet antibody is mostly decrease. There will be decrease in the patient will be presented with decrease in the platelet in the reproductive age group, a female patient, but there will be no spleen, or there won't be any abnormality in the peripheral smear, and we need to suspect the ITP. That can be a primary or it can be secondary. Always rule out the secondary causes of ITP. So it can be an SLE, it can be RA, it can be HIV, it can be HCV, most commonly. Then we have a hematological manifestation of the lupus. So we know there will be thrombosis, there will be leukopenia, there would be thrombocytopenia, there will be chronic anemia, normocytic normochromic anemia, leukopenia, okay, lymphopenia. Then we have anti-glutamate antibody or anti-neuronal antibody. Now this is mostly associated with that of CNS involvement. So we have this cognitive dysfunction in the patients of SLE. Then we have anti-ribosomal, that is mostly psychosis and depression. Okay, so this is also have been MCQ. Then we have a biomarker. So remember, not all inflammation we have increase in ESR and increase in C-reactive protein. No, okay, there is no increase in C-reactive protein. In fact, there is decrease in C-reactive protein. That doesn't mean there is no infection and there is no inflammation. We need to see for the ESR. There are anti-C-reactive protein antibodies also. So there is anti-C-reactive protein antibodies, and There is CRP polymorphism. Interferon alpha suppresses CRP, right? Clinical features being, it includes constitutional symptoms, fatigue, fever, weight loss, skin, joint symptoms, pyrexia of unknown origin, weight loss, fatigue. We all know that. Okay, so we have seen 5 patterns of the homogeneous one. Then we have a remorse peripheral. Then we have speckled pattern. Then we have the our centromere pattern. Okay, then we have antinucleolar pattern. So we have already seen these patterns. Okay, I'm repeating this because it is very confusing and we need to know this, because clinically even we have to locate where the patient is in which class, and what should be the next best management for him, the prognosis part. We need to even counsel the patient for the injections and for the repetitive admissions. Okay, then we have different antibodies, anti-double stranded DNA antibodies, anti-Smith, anti-UNRNP. Then we have anti-Rho or La, anti-RBC, anti-platelet, anti-glutamate, anti-ribosomal. Okay, so cutaneous lupus, that is actually a specific lupus erythematosus, and we have a non-specific one. Coming to cutaneous, acute cutaneous, so this is a specific one. So specific, we have acute cutaneous, we have a chronic cutaneous, and we have a subacute also. So coming to acute cutaneous, now this acute cutaneous, we have a very specific pattern for it. We know that there is a malar rash. This is actually an erythematosus, right? Okay, so erythematous rash is present. This is symmetrical. Okay, this is focal. This is not pre-malignant. It is photosensitive. Okay. So very important, whenever patient would be describing this, or any of your relative would be describing it, or the MCQ describes it, you need to know this. It is also pre-malignant. People may be asking you. So erythematous rash, malar rash, photosensitive, non-scarring, non-pre-malignant, sparing the nasolabial fold, focal and symmetrical. So we have all been familiar with this rash. Now we have a acute cutaneous lupus erythematosus. Okay, so we have this localized, we have the malar rash in this. Now we have a generalized one. Okay, for the generalized one, we have a morbilliform rash. This is actually coming in acute cutaneous itself. Okay, and then we have a toxic epidermal necrolysis. Okay, so we have acute cutaneous, we have subacute, we have a chronic. Then in case of acute, we have the subgroups, that is the classic rash, which we have already been very familiar with, and we have a generalized one, that is a morbilliform. Morbilliform is the rash which will be present. Generalized, that means it will be present anywhere, it can be present anywhere, but sparing the knuckles. Okay, so we need to know this, sparing the knuckles. Okay, then we have a toxic epidermal necrolysis. That is actually a worst thing. Okay, everywhere rash will be present, mostly in the trunk and the facial part. Then there is this chronic cutaneous lupus. Chronic cutaneous lupus, we have a discoid type of rash. So very famous saying that 5% of the discoid lupus will be presenting with the SLE, and 20% of the SLE will be present with that of the discoid rash. So this is completely ulta, pre-malignant, scarring. Now 2 or 3 names you should be features which should be known to you. Keratotic scarring, follicular plugging, dermal atrophy. Pre-malignant, scarring alopecia, circular erythematous rash. You see this, okay? And scarring alopecia. If it is present on the back, carpet tack epidermis. Okay? Then in that only, in chronic cutaneous, we have 4 other types. There is chilblain lupus, mostly chilblain. Why? Cyanotic area, like it will be presenting with lupus paniculitis, lupus profundus, verrucous lupus. Okay, this is lupus paniculitis, lupus profundus. Then we have a subacute cutaneous one. So it is the middle of the both. Superficial skin involvement, non-scarring, highly photosensitive, anti-Rho and La associated with it. HLA-DR3, already we have seen HLA-DR2, DR3, DR3 associated subacute cutaneous lupus. It has a better prognosis, sparing the facial regions. We have a slick classification criteria for SLE. We have a clinical criteria and we have a immunological criteria. Clinical criteria says that there is an acute and chronic cutaneous lupus. Along with that, there is nasal ulcers, okay, and a non-scarring alopecia. We have arthritis, serositis, renal, neurologic neurological involvement. Hemolytic anemia, leukopenia, thrombocytopenia. Immunologic criteria, we have ANA, we have anti-double stranded DNA, we have Smith, phospholipid antibody, low complement, direct homeostasis. So clinical criteria, acute and cutaneous lupus, first of all. Then we have nasal ulcers or oral ulcers. Then there is the non-scarring alopecia. Then the systems are involved. That means there would be involvement of renal, there is serositis, there is neurologic involvement, okay? There is arthritis. Then the blood part, hemolytic anemia, thrombocytopenia. Then we have leukopenia. Arthritis is the most common system to be involved, they say. Okay, so how is the presentation? Mostly the small joints, upper limb, symmetrical. Okay, this is the most commonly involved. So uniform, bilateral, symmetrical, upper limb, small joint, polyarthritis, and it is a non-erosive. If it had been erosive one, we say it is a Jacob's arthropathy. And we have a deforming, if it is a deforming one, then it is a Jacob's arthropathy. Okay, erosive and all, it is present in RA. Okay, I'm very sorry, erosive is present in rheumatoid arthritis, and if it is a deforming one, it is in Jacob's arthropathy. Septic arthritis, how will we identify the patient? Of course, he will be in a toxic illness, right? Pain, redness, inflammation of only the single joint, okay, mostly. So this is the identification of septic arthritis. Other organs, vascular system. Why vascular system? Most common cause of the death is acute coronary syndrome. Okay. Okay, so this is very important. More than 10 years of the age, there will be accelerated atherosclerosis. Very important. So vasculitis, in the vasculitis also we have something common and something we have rare. So cutaneous leucoclastic vasculitis, which is the most common, rare is the mesenteric vasculitis, and CNS vasculitis, stroke or seizures. Then we have a CVS, okay, cardiovascular system. In that we have a pericardial effusion without the tamponade, pericarditis, myocarditis, Lipman-Sachs endocarditis. Valvular we have MR. So mostly CVS involvement is like pericarditis is more common. Other than that, we have not seen much of the cases. In the lungs, most important part you need to remember, no ILD. Okay, we need to get this into our head. There is no interstitial lung disease. Other things like lupus pneumonitis, or we have shrinking lung syndrome. Theoretical part is very important, shrinking lung syndrome, otherwise practically no importance. Pleuritis with that of the effusion will be present. It will be exudative one. Lupus pneumonitis, shrinking lung syndrome. Whenever SLE along with the scleroderma overlap is present, then there will be present of increased risk of PAH. Okay, pulmonary arterial hypertension. So we see an SLE flare, that means the patient is on the immunosuppression, okay, on the drugs, okay, but there will be much more of increase in the ESR, and there would be a diffuse alveolar hemorrhage like a picture, okay, where you can see this. So do not ignore these patients with the hemoptysis and cough and dyspnea, everything. So with the tapering doses of steroids, we have the increase in the ESR, and there is no CRP, there is no ANA, low C3, C4, and there is increase in the double stranded DNA. So SLE flare, that is mostly DH, right? So ESR will be helping us to find out. In GIT, we have autoimmune hepatitis and lupus enteritis, most commonly autoimmune hepatitis. CNS, we have already seen thrombosis, APLA, okay, and then anti-ribosomal, okay, anti-glutamate, okay, cognitive dysfunction, then CNS vasculitis, plasmapheresis is required. See, plasmapheresis is something which is done in 2 or 3 indication, very very important, create more than 5.5, or we have CNS vasculitis, okay, or we have the DAH, which is seen in the Gush pastures. So mostly this is very important, okay, 3 indications. Anti-ribosomal P, anti-double stranded polyneuropathy. With the rituximab use, we have progressive multifocal leukoencephalopathy, can be an MCQ, okay, with rituximab. Coming to the treatment part. So whenever skin and joint involvement is there, we need to start on low dose of the steroid along with that of NSAIDs and with the hydroxychloroquine. Trials have shown hydroxychloroquine is very good, effective, okay. Second line, of course, we can go to methotrexate, azathioprine, belimumab. Now we have not talked about the lupus part. Okay, we will be talking about the lupus part because renal involvement is seen in 50% of the patients, so very important to talk in detail. So let's just come to the treatment part and then we'll talk. Okay, so we have a class 5 lupus. Okay, lupus nephritis. Okay, remember we have classes, 6 classes, class 1 and 2 mild type. Okay, no treatment is required. We can do the biopsy. Okay, in biopsy we will be showing like minimal, no creat erased. Okay, there will be no urine routine microscopy. So mostly the picture is very fine and very normal. There is no treatment to it. Of course they can present with the lupus porocytopathy. Okay, class 1 and class 2. Now we come to class 5. Okay, this is the membranous part type. Okay, now this is presenting with like that of a nephrotic syndrome. So whenever a patient is having a proteinuria, okay, now we need to divide it if it is less than 1 to 2 or more than 1 to 2. Glucocorticoid is mandatory, but along with that what can we give? So if it is less than 1 to 2 gram, we can of course handle with that grass. But if it is not less than 1 to 2, it is more than 1 to 2 gram per day, then we need to give glucocorticoid. Along with that we need to give the mmf. Okay, so very important. If there is no response, calcineurin inhibitors, or we have a rituximab. Now if there is active lupus, okay, if there is an active lupus, then there is something which is called as induction. So this induction is starting with that of MPS, of course. Okay, god of everything. 1 gram, 500 to 1 gram MPS is given for 3 days, and then we need to give 1 milligram per kg full doses for that of 6 to 8 weeks, and then we taper off it. Okay, so 500 to 1 for 3 days consecutive, and 1 milligram per kg 6 to 8 doses. Then 3 months we need to look after the patient, we need to see, we need to do all the investigation, reassessment done. Along with that we need to give the IV cyclophosphamide, that is 500 to 750 each month. Okay, 1 dose. So 6 doses, 1 dose every month. And it can be 500 can be given once every 2 weeks also. Okay, or we can give mmf, cyclophosphamide or mmf. Now if only 50% of the response can be seen at 6 months, at the 3 months when we are reassessing the patient, if there is a partial response or there is no response, then we can change the regimen. If the patient has been started with say MPS and cyclophosphamide, we can change to MPS and we have can be changing to mmf. Okay, resistant lupus nephritis, that means there is persistent proteinuria. Okay, there are urine sediments. Okay, and there is symptoms also, and there is increase in the serum creat. So there is resistant lupus. Okay, for the resistant lupus we need to give rituximab. Okay, mostly rituximab has been used. There can be extended course of cyclophosphamide, there can be multi-target therapy, IVIG, therapeutic plasma exchange, immunoablation, and we have the stem cell transplantation also. For the maintenance one, so we need to remember R for R. For the maintenance treatment options, we need to give MMF, that is also M for M. Okay, along with that we of course we can also give azathioprine, cyclophosphamide, cyclosporin, tacrolimus, and along with that also we need to give the low dose of prednisolone, that is 0.02 to 0.5. Okay, 0.05 to 0.2 milligram per kg. Okay, never stop prednisolone before 1 year. Okay, because there can be, of course there won't be remission, there will be relapse. And of course we need to see for the compliance of the patient with all these medication. So starting we have induction, we have the MPS 3 doses for 3 consecutive days. Okay, and then we need to give 6 doses, 1 milligram per kg, and then we need to taper off. And of course we need to give cyclophosphamide reassessment to be done 3 months. Cyclophosphamide can be given 2 weeks per once in 2 weeks, or we can give it for 1 dose each month for 6 doses. Okay, and of course we can change. There is something which is anifrolumab that is coming up, which is targeting type 1 interferon system. Okay, so we have a drug induced lupus, okay, drug induced SLE. So chimp q we need to remember carbamazepine, chlorpromazine, what these are the drugs. Then we have hydralazine, isoniazid, interferon, infliximab, methyl-dopa, minocycline, procainamide, phenytoin, propylthiouracil, penicillamine, quinidine. So we have already seen these have 100% ENA positive. What are the other two? It is the mixed connective tissue disorder. We have autoimmune hepatitis and we have drug induced. Okay, MAD. We've already seen that. It has a homogeneous pattern. Antihistone antibodies, male and female equal. We have symptoms arthralgia, myalgia, fever, serositis, skin lesions also can be present, but CNS and kidney involvement is not present. Now, lupus in pregnancy, very often asked if the fertility will be affected. No, fertility is not affected, but of course there can be miscarriage because of the APLA, of course. Now, the drugs that can be used are hydroxychloroquine, steroids, and we have calcineurin inhibitor. MMF and cyclophosphamide are not given. Okay. Coming to the lupus nephritis, 50% of the patients have the renal disease. Very bad. We have proteinuria, we have hematuria, we have hypertension, we have renal failure in them. So of course there is anti-double stranded DNA positive. Okay. We have this classification, that is class 1, which is minimal mesangial. Then we have mesangial proliferation 1. Then we have focal nephritis. Then we have diffuse nephritis. We have class 5 membranous. We have sclerotic. This is the hopeless one because the sclerosis have taken place. Now they say that class 4 prognosis is bad than class 5 because it is a diffuse nephritis, and diffuse is anti-double stranded DNA and everything is positive in this. Okay, so we know APLA antibodies are there. Okay, this all we have studied that cyclophosphamide is given. Okay, MMF can be tried. Then if there is renal failure, okay, nothing has helped this patient, renal transplantation is the option, but only after 6 months of inactive disease. Okay, increases the allograft survival rate only after 6 months of inactive disease. Class 1 and class 2, no treatment is required. Now, when the biopsy to be done? Big question. If the proteinuria is, or the 24-hour urinary protein is more than that of the 1 gram per day, or we have more than 500 milligram with that of the RBC in the urine. So that is an indication for the biopsy to be done. So biopsy, class 1 and class 2, normal create, we get discussed already. There can be lupus porocytopathy also. Class 5 1, membranous, okay. There is subepithelial, okay, immune complex deposits, IgM, IgG3. These are steroid unresponsive and have better prognosis than class 4, presents as nephrotic syndrome. Now we have this wire loop lesion, okay, that is seen in class 3 and class 4. And we have a full house effect, that means everything, IgM, IgG, IgA, C3, every deposits are seen over here. Then specific finding for SLE, we have hematoxylin bodies in these. So there is this modified NIH activity index and we have modified NIH chronicity index. So we have the scoring also to them. Whenever a neutrophil infiltration is present, or we have interstitial inflammation, wire loop lesions, endocapillary hypercellularity, cellular crescents, fibrinoid necrosis. So this is coming into our activity index. Chronicity index, we have sclerosis more often. Okay, so we have glomerulosclerosis, we have fibrous sclerosis, we have interstitial fibrosis, we have tubular atrophy in this. So the scores can be asked, okay, as an MCQ. Which of them are being included, which are not included. Okay, I hope you people have enjoyed this topic. Go through it, study, and let me know if you have any queries regarding them. Okay, thank you so much for watching.